Decide prophylactic antibiotic in a patient listed for theatre. What factors you will consider in?
I will consider the patient comorbidities and whether he is more liable to have any infection, like if he is immune compromised patient taking a steroid, renal a transplant patient. Also about the disease of the patient, whether he has an infected problem at the moment, like abscess or something else, or we are doing a clean surgery for the patient. So whether it's a clean contaminated or contaminated surgery, and depend whether we are putting any prosthesis or not, depending on the expected microorganisms, whether they are mainly gram-negative, gram-positive, or anaerobic. And then accordingly, I can decide on the prophylactic antibiotic.
Could you tell me some examples for clean surgeries in urology?
So clean surgery in urology, most like varicocele ligation, inguinal radical orchiectomy, orchidopixy. Most of these surgeries, since there is no involvement of the mucosa of the urinary tract, then should be a clean surgery.
Say, for example, simple nephrectomy for a non-functioning kidney. How will you classify it?
I would say it will be a clean contaminated, because there is a potential risk of contamination during dissection and division of the ureter in this kidney, and we are entering a body cavity, so it will be clean contaminated.
So how will you use these factors to decide the prophylactic antibiotic?
So usually for the clean surgery, we don't need to give antibiotic unless the surgery involves a prosthesis insertion. Then we need to give. For the clean contaminated, we need to give antibiotic, usually a single dose with the induction of anesthesia. While for the contaminated cases, we need to give prophylactic antibiotic at the time of anesthesia, and then to continue antibiotic therapy for a few days after that.
Okay, say for example you are doing a prosthetic surgery. Give an example in urology and what is your choice of antibiotic?
So, for example, when we do TRP, if the patient is not having a catheter, usually we prefer to give the patient something which cover mainly gram-negative microorganism, like gentamicin at a dose of 5 milligram per kg.
Okay, give example for surgery in urology which involves a prosthetic placement.
So prosthetic placement, like when we put testicular prosthesis, for example, in this case, we are concerned about mainly the gram-positive microorganism rather than the gram-negative. So I need a wide spectrum antibiotic, including gram-positive like coamoxiclav or second generation cephalosporin.
So how many doses you will give?
So usually for the prosthesis, we needed to give a dose of at the induction of anesthesia, and usually I will cover the patient for 24 hours with antibiotic following prosthesis insertion.
Okay. What is the antibiotic of choice for transperineal prostate biopsy?
In transperineal prostate biopsy, in my practice, we are using ciprofloxacin 500 milligrams single oral dose 60 minutes before the procedure. However, the incidence of sepsis and infection in TP biopsies are very, very low at 0.16%. And I am aware of recent studies by Castellani from US, which compare patient underwent TP biopsies with or without antibiotic, and actually there was no significant difference in the infection, sepsis, and readmission rate between prophylactic antibiotic and no antibiotic before TP biopsy.
Okay. You said you used gentamicin, one of the commonest prophylactic antibiotic in urology surgeries. What is the dose? How will you decide the dose?
We decide the dose according to the body weight, and the usual dose for gentamicin is 5 to 7 milligram per kg, providing that the patient is having adequate renal function.
What is the dose for prophylactic gentamicin?
So for prophylactic gentamicin is usually I will give 3 to 5 milligram per kg.
Okay. What is gentamicin? How it works?
So gentamicin is a bactericidal antibiotic. It acts by inhibiting of the ribosomal subunit of the bacteria, and by this it inhibits the protein synthesis.
Okay. Is it a broad spectrum? What kind of organisms it will cover?
It's mainly cover gram-negative, but also it has some effect on the some gram-positive like staph.
So what about co-amoxiclav?
Comoxiclav is a combination of amoxicillin and clavulanic acid, which is a beta-lactamase inhibitor. And usually it covers a wide spectrum of antibiotic, mainly gram-positive, with a good cover of gram-negative as well.
Okay. What is the dose for the patient?
For adult patient, comoxiclav is 1.2 gram 3 times daily.
Okay. What is
Injectable.
sorry?
Sorry, this is injectable, and the oral is 625 milligram 3 times orally.
Okay. What is the antibiotic regimen for community acquired epididymoarthritis?
It depends on the patient age. How old is the patient?
21. Sexually active.
Okay, so usually for the patient less than 35 years of age who are sexually active, we think about possibly an STI as a cause for epididymoarthritis, and therefore we give the patient something effective against chlamydia, mycoplasma. Therefore, I will give the patient usually a levofloxacin, 500 milligram once daily for 14 days, because levofloxacin is very effective against the gram-negative bacteria and also effective against chlamydia. If the patient is having discharge and the urethral swab is showing an Neisseria, gonorrhea, then we need to treat gonorrhea usually with a single dose of ceftriaxone given 1 gram IM, or a single dose of azithromycin 1 gram oral. So I will treat for 2 weeks.
Okay. Your theatre team is preparing mitomycin to be given after your TURBT for a newly diagnosed bladder possible TCC lesion. What is mitomycin? Why you have to give immediately after TURBT?
So mitomycin is antibiotic chemotherapy. It will act by inhibiting the DNA synthesis on the on the S1 and G phase of the cell cycle. It has a proven effect to reduce the recurrence of non-muscle invasive bladder cancer, and there are meta-analysis by Sylvester et al., which showed that a single dose of mitomycin postoperatively following resection of bladder tumor, it will reduce the there will be a relative risk reduction of 39% and absolute risk reduction of 12% if it is given early in the postoperative time to reduce the recurrence.
Okay, so how will you give? What is the dose?
So the dose is 40 milligram in a 40 ml of distilled water. Usually it is given immediately, in my practice, immediately after the TURBT. Make sure that there is no risk of perforation, there is no significant hematuria, and then the medication, usually it's a purple color, will be infused by gravity, by a special application system through the catheter, and the catheter will be clamped, and we ask the patient usually to move into different position. We keep the fluid usually for around 1 hour, and then after that we unclamp the catheter if there is a need to keep the catheter longer. Otherwise, we can take the catheter out, and the patient will pass the mitomycin. We warn the patient and the nurses try to avoid contamination with the mitomycin, because it may cause a chemical dermatitis of the palm of the hand and the legs. And I will put in the operative note very clearly the time mitomycin was instilled, the dose, and a clear instruction for the nurses in recovery to unclamp the catheter, usually within 1 hour.
Why you
After that, all the instrument or everything used should be go into a specific bin, which is a purple lead bin, and we should use a universal precaution during that.
why you have to ask the patient to turn into different positions? What is the use of it?
In order to give the maximum exposure of all parts of the bladder.
Okay. What is BCG? What do you mean by the BCG regimen? From where it's derived from?
So BCG is liver attenuated Mycobacterium bovis bacteria. It is used in a patient with high risk non-muscle invasive bladder cancer. Excuse me. So it's used in patients with high risk non-muscle invasive bladder cancer in order to reduce the chance of recurrence and the progression. It will act by induce a local immune reaction. When the BCG is given, it will attach to the epithelial cell via fibronectin receptor, and then after that, it will enhance the antigen presenting cell to T lymphocyte. Therefore, by this enhance the T cell mediated killing of malignant cell, and there is evidence that this will reduce the recurrence and the progression. Again, there is a meta-analysis review by Sylvester et al. Which showed a relative risk reduction of 27% and an absolute risk reduction of 4% in the progression of bladder cancer over 5 years with the use of BCG.
Okay, we'll stop there. As I said, I have no major concerns and nothing to suggest. You are on the right track for a very good exam performance and very good result. And I think you need some voice rest and take some prophylactic antibiotics. I'm not a person who support antibiotics, but before the exam, you can do anything under the sun to make yourself comfortable. And any help from us, please feel free to ring anytime. There is no office time, non-office time or anything like that. If you are free, we will try to do something tomorrow afternoon, almost the same time.
Yeah, thank you very much. Really appreciate your help and support during this time.
Good. Have a nice evening.
For you as well. Thank you very much.